like to thank you for taking the time to join me on this week's video. I'm very excited to be with you this week because we're beginning today part 1 of a 4-part video series related to gait disturbance and assistive devices. Gait disturbance and assistive devices. And I'm happy to say that the feedback that I've been getting from you doctors on the video trainings that we have already published regarding gait disturbance, Chapter 13, Chapter 15, and Chapter 17, has been extremely well received. So I want to thank you for your kind feedback and your kind comments. And we're pushing forward with the very specific intention today to expand our knowledge and our awareness of permanent impairments as they relate under the strict application of the AMA guides, and also by analogy to station and gait disorders in Chapter 13, and gait derangement as described in Chapter 17. And I'm extra excited to be bringing this material to you because this marks the second edition of our QME Continuing Education Home Study Program entitled Gait Disturbance and Assistive Devices. And that program has now been expanded to 6 hours. It was formerly only a 3-hour program, but it's been recently expanded and completely updated with fascinating video depictions of gait derangements, fascinating discussions of permanent impairments related to gait disturbance. And so it's a brand new program, and my memory is fresh up to the moment about all topics related to gait and gait disturbance. So I'm super excited to be with you here today. Now, this is a 4-part series. We're going to begin today by talking about the philosophy of Chapters 13 and Chapter 15. Next week, we'll get into the gait cycle, and we're going to talk about the phases of normal gait. We'll talk about the stance phase of gait, the swing phase of gait, and we'll break down the gait cycle into manageable increments in detail sufficient to enable us to understand Chapters 13 and Chapter 17 and the discussions in those chapters as related to derangements of the normal gait cycle. So we'll talk about many of the subphases of the stance phase of gait, many of the subphases of the swing phase of gait, and we'll get on common ground and on the same page as to what constitutes normal gait and therefore what constitutes pathologic gait that could qualify for permanent impairment. And in this discussion, we'll also go over some of the causes of gait disturbances, and we'll describe many of the named gait signs that we're familiar with, such as Antalgic gait, Trendelenberg gait, gluteus maximus gait, festinating gait, and many other types of gait disturbances that we see in the industrial setting. On the 3rd week, we're going to go over the procedure involved with conducting the formal gait analysis. And I'll talk a little bit in today's discussion under philosophy about the necessity. Did I say necessity? About the necessity of performing some sort of formalized procedure for the assessment of gait. In other words, if you're going to provide for permanent impairment due to station and gait disorder or due to gait derangement, should you have some sort of objective findings to substantiate your opinion and your conclusion on permanent impairment? Should you have some sort of objective findings to substantiate a permanent impairment rating of beginning with 7% in Chapter 17 for the lowest level of impairments? Those begin at 7%. Those are large permanent impairment ratings, and they escalate from 7 all the way up to 80%. 80% in Chapter 13. Should you have some sort of objective findings to substantiate your opinion or conclusion for permanent impairment due to gait disturbance? Yes, you should. You should be able to substantiate your opinion with clinical findings. And the clinical findings begin at least, and we'll talk about this in great detail when we get there, and we'll touch a little bit on it today, but your objective findings for gait disturbance and permanent impairment due to gait disturbance begin with some formal gait analysis, and I'll provide for you a practical procedure that you can immediately integrate into your normal physical examination routine for the assessment of any possible station and gait disorder or any possible derangement of gait disorder. And we'll go into great detail as to exactly how to perform a gait analysis and how exactly to provide for permanent impairment by citing the positive objective findings associated with derangement of gait. And then finally, in the fourth week, we're going to talk about assistive devices. And it's interesting because the AMA guides describe several different types of assistive devices, such as canes, such as crutches, such as walkers, such as ankle and foot orthoses, and knee and ankle foot orthoses. And I realized in reviewing the AMA guides that I really had no formal training in these assistive devices. So I thought it would be a good idea to prepare some material for you to help you in your evaluation of injured workers who show up to the evaluation with one or more of these assistive devices. You know, we're all familiar with examinees, injured workers, who present to the QME evaluation with some sort of an assistive device. And let's just use a cane as an example. How do we know, or how do we establish, and this is just a hypothetical question to stimulate your interest for when we get to this section of this program, how do we know, or how do we establish the medical necessity of the assistive device under the workers' compensation claim? How do we know whether or not the examinee actually requires the use of the assistive device? How do we determine if the assistive device is an objective finding that contributes to the permanent impairment? We'll talk about those and many more issues when we get to part 4 of this 4-part series on gait derangement and assistive devices. Okay, so I want to begin with part 1 of this program, which is all about the philosophy of gait derangements as described in chapters 13 and chapter 17. So I'll give you a minute to go ahead and get your AMA guides, and I want you to actually go ahead and get your AMA guides so that you can follow along with me as we describe the permanent impairments exactly as those are described in both of those chapters. So look forward to being back with you here in just a few moments as we get into today's topic on the philosophy of gait disturbance and assistive devices. Okay, I'm back with you now and have my AMA guides with me, and hope you have your AMA guides with you as well so that you can follow along with today's material. And I want to begin this section of the program with just a little philosophy, and that's the overriding topic of today's presentation, is the philosophy of gait disturbance and assistive devices, the philosophy of providing for permanent impairment due to derangement of gait and station and gait disorders, and the philosophy of your physical examination as it relates to providing for permanent impairment due to these conditions. Now it's interesting because I love the AMA guides and if you've been doing qualified medical evaluations for any length of time, and if you're anything like me, your appreciation for the AMA guides grows with time. I've really come to appreciate the AMA guides, because the AMA guides, and they'll even tell you this throughout the guides themselves, the AMA guides are largely based on positive objective findings. Positive objective findings. And I've discussed the nature of true objective findings in other lessons and other video tapings, so I won't reiterate that whole topic here. But suffice to say, the AMA guides are all about positive objective findings. Well, when it comes to providing for permanent impairment due to station and gait disorder in Chapter 13, or gait derangement in Chapter 17, a normal natural question arises, and that is, what type of positive objective findings would you expect to be associated with someone who has indeed a permanent impairment of a gait derangement, or a permanent impairment of a station and gait disorder? And I find through these trainings and through the continuing education home study programs that we've published on this topic, doctors are embracing this idea more and more, specifically as relates to gait disturbance and assistive devices. So I'm thrilled about that. And the purpose of today's video is to bolster those of you who are performing a thorough and masterful physical examination for the assessment of gait. And for those of you who have not yet embraced this idea, I hope to encourage you about the necessity of actually doing so. So in order to establish the necessity of performing a fabulous physical examination associated with permanent impairment due to gait disturbance, I want to begin in Chapter 13 and then move to Chapter 17. And what I want to do is I want to review with you the permanent impairments exactly as they're described in these two chapters. And I think when we review these together, you will have a revelation that you may need to ramp up your physical examination procedures associated with gait. Okay? So, with that as our philosophy, let's go to Chapter 13. Okay, so we're on page 336, Table 13-15. Now, Table 13-15 describes the criteria for rating impairments due to station and gait disorders. Now, recall that Chapter 13 is the central and peripheral nervous system chapter. So in Chapter 13, we're considering those examinees who have station and gait disorder due to some type of injury to either the peripheral nervous system or the central nervous system. So let's just stop right there. Let's imagine in our mind an examinee who has some type of injury to the peripheral nervous system or some type of an injury to the central nervous system that leaves them with some gait disorder. I want you to picture that in your mind. What do you conjure up in your mind when you consider such an examinee? Do you think of an examinee who perhaps has a drop foot? Someone who possibly has an L5 nerve root lesion, or a common peroneal nerve lesion that leaves them with paralysis or weakness of the anterior tibialis muscle? That would be an example of a peripheral nerve lesion. Someone who has injury to the common peroneal nerve. There's a peripheral nerve lesion. What about someone with a central nervous system lesion? How about an examinee who has cerebral palsy? You're all familiar with the typical gait associated with cerebral palsy, the so-called spastic gait. So these are examples of peripheral nervous system disorders and central nervous system disorders, and I want you to keep those in the back of your mind as you consider these types of examinees. These are examinees with significant conditions who would also have would also have significant, positive, objective physical examination findings. So consider the examinee with drop foot. He would have significant, positive, objective examination findings that would be consistent with a gait derangement that we would typically call, we would refer to it as a drop foot. What kind of positive physical examination findings would you expect to see in an examinee with cerebral palsy? They would have positive objective findings, correct? So part of the philosophy of this program is that if you're going to provide for permanent impairment due to station and gait disorder, whether under the strict application of the AMA guides or even by analogy, the impairment rating should be substantiated by positive, objective physical examination findings, okay? So in table 1315, they describe four classes of station and gait disorders. And these are a progressive classification system, beginning with low levels of permanent impairment to almost complete loss of the ability to ambulate at all. Okay? So let's describe these. So for example, a class 1 impairment is an examinee who is able to rise to a standing position. They're able to walk, but they have difficulty with elevations, grades, stairs, deep chairs, and long distances. So I want you to picture this examinee in your mind. Okay, and they have some sort of a peripheral nervous system disorder, a central nervous system disorder, and they're able to rise to a standing position. They can get up, they can walk, but they have some difficulty with elevations, grades, stairs, deep chairs, and long distances. Would this perhaps describe a person who has drop foot? It could, couldn't it? They can walk. A person with drop foot can walk. I've treated many of these cases in my clinical practice, and they can walk, but they do have some difficulty. They have some difficulty. It's awkward, it's fatiguing. Is this perhaps consistent with someone who has a drop foot? It could be. Is this consistent with someone who has a spastic gait due to cerebral palsy? They can walk, correct, can't they? I can tell you that they can walk because I drive by a person every day who walks considerable distances. And it's difficult. It appears to be difficult, but he does it. He can walk. I've seen him. I've passed this same person every day for the past decade. And I see this person walking great distances between major city blocks in the Sacramento region. They can walk, okay? But there is some difficulty. Okay, a class 2 impairment is a person who rises to a standing position. They walk some distance with difficulty and without assistance, but they're limited to level surfaces. They rise to a standing position. They walk some distance with difficulty. Well, here's a vague description in the AMA guides. They don't tell us what some distance means. What is some distance? Is it 100 yards? Is it 2 miles? The AMA guides aren't clear on that. But they give further descriptors by saying that they're limited only to level surfaces. Okay? Class 3 impairment is an examinee who rises and maintains a standing position with difficulty, but cannot walk without assistance. They rise and maintain standing position with difficulty, but cannot walk without assistance. This is due to a central or peripheral nervous system disorder. Now I want to give you an example. In my health club in the morning, there's a gentleman who works out in the health club in the morning. He's approximately 70 years old, and he has bilateral drop foot. And I spoke to him the other day and I said, hey, do you have a drop foot? Looks to me like you have a drop foot on the right, I said to him. And he said, actually I have a drop foot on both feet. I've been diagnosed with peripheral neuropathy, similar to what we were talking about with a lesion to the common peroneal nerve. So he has bilateral drop foot. In my opinion, the right drop foot is greater and more pronounced than the left drop foot. But you can hear him slapping along as he comes down the corridor at the gym. He walks with some difficulty, but without assistance. A class 3 impairment is an examinee who cannot walk without assistance. I want you to picture that in your mind. What type of an assistance? What type of assistance? Either with an assistive device, such as a walker, such as 2 canes, 2 crutches, such as assistance from a third-party person, okay, cannot walk without assistance. A significant impairment that would be accompanied by true positive objective findings, correct? There would be true positive objective findings in this examinee. We're not often going to see this type of examinee. Class 4 impairment is an examinee who cannot stand without help, They cannot stand without mechanical support and or an assistive device. Now, this would describe someone with either paraplegia or quadriplegia. And I'm thinking in my own clinical practice back to a time when I had a 12-year-old boy who was involved in an auto accident. He was riding his bicycle and he was struck by an automobile, and he was rendered paraplegic and very weak in the upper extremities. He was not completely quadriplegic. He had some limited function of the upper extremities, but the lower extremities were exactly as such. He could not stand. And I remember propping him up in front of the x-ray tube one time to get some x-rays of him. He had to be supported there by an assistant. And he was able to support himself with one hand, and the assistant supported him with the other hand. And then once the x-ray was obtained, we quickly got him back into his wheelchair. And that's an example of an examinee who cannot stand without help. And now this type of examinee would certainly have significant positive objective findings, neurologic physical exam findings, correct? Okay? So let me ask you this question. If you're going to provide for permanent impairment due to any one of these classes of permanent impairment, and certainly it would be more common to use the class 1 or class 2 impairment, because we simply don't see that many examinees with the class 3 and class 4 impairments. But let me ask you, if you're providing for permanent impairment due to class 1 or class 2 impairment, what kind of positive objective findings would you expect to be associated with these impairments? And while you think about that for just a minute, and I ask you that question to persuade you of the necessity of performing a brilliant physical examination that's consistent with the permanent impairment rating. Second question I want to ask you is, of these descriptions of permanent impairment, these criteria that are described in table 1315, well, let me just illustrate this by referring to the class 1 impairment. This person can rise to a standing position. They can walk, but they have difficulty with elevations, with grades, with stairs, with deep chairs, and long distances. Let me ask you, of those criteria, which of those criteria are criteria that we as qualified medical evaluators can, with our own eyes, observe during the qualified medical evaluation. Can we observe the examinee to demonstrate to us objectively difficulty with long distances? Do we have the chance to go out with an examinee and walk for 4 miles with them to observe that indeed, at the 3rd and 4th mile they do develop difficulty? We don't have that opportunity, correct? Okay. Do we have the opportunity to be able to observe them having difficulty with elevations and grades? We don't. How about with stairs? Probably not. Unless you have your examinee go up and down stairs in the evaluation office or somewhere outside, we can't corroborate their description of difficulty with stairs. What about deep chairs? Possibly we could observe that during the physical exam or interview, correct? Many times the examinee would demonstrate difficulty in getting out of a deep chair by using their hands to assist them. We refer to that as a positive minor sign, correct? We typically associate that with some sort of a lumbar spine or lower extremity injury. We could possibly observe that, but don't many people help themselves out of a chair, especially a deep chair, with their hands? How do we know that the examinee has true difficulty? How do we know that the examinee has difficulty with stairs? How do we know the examinee has difficulty with distances? We don't. We don't. We simply take their statement that they have difficulty with distances, that they have difficulty with elevations, that they have difficulty with grades. We take their subjective statements and we provide for permanent impairment ratings based on those subjective statements without any associated positive physical examination findings. And the philosophy of today's program is that there must be positive physical examination findings to support your permanent impairment rating. Otherwise, the permanent impairment rating does not qualify as substantial medical evidence because the opinion for permanent impairment is not backed up by an adequate exam. It's not backed up by an adequate exam. And you remember from the Escobedo case, we learned the criteria for how to qualify opinions and conclusions as substantial medical evidence. And one of those criteria is that the opinion and conclusion has to be based on an adequate exam. How can we provide for permanent impairment due to station and gait disorder without an adequate exam? So it raises the question, what is the adequate exam? And that's the whole purpose of this 4-part series, is to persuade you and convince you to integrate and implement a formal gait analysis into your routine procedure. Okay, so chapter 13 requires it. It requires it. The AMA guides don't say that there's any specific procedure involved with an analysis of gait, but it's my opinion that it's required in order for your opinion to qualify as substantial medical evidence. Okay, what about now in chapter 17? Let's go to chapter 17, talk about permanent impairments there. And this is on page 529, and this is table 17-5. Table 17-5 provides for lower extremity impairment due to gait derangement. Okay? Now in this table, they describe 3 levels of impairment. Remember in chapter 13 we had 4 classes. In chapter 17 we have 3 levels. So we have mild impairments, we have moderate impairments, and we have severe impairments. Now most of the time, if you're going to provide for permanent impairment in chapter 17, would be due to a lower extremity injury, not due to a central nervous system injury, but perhaps due to a peripheral nerve injury of the lower extremity or a lower extremity orthopedic injury. Typically, we would be considering the mild impairments rather than the severe impairments. So let's go over these impairments one by one, and we'll talk about the more common scenarios. So the mild impairments describe a progression of increasing impairment of the lower extremity, increasing impairment, for which there is increasing permanent impairment rating, numeric rating, okay? So the lowest level of permanent impairment, the lowest form of a mild impairment, provides for 7% whole person impairment. And this is an examinee who has an antalgic limp with a shortened stance phase and has documented moderate to advanced arthritic changes of the hip, knee, or ankle. And this is fascinating. This is fascinating. The AMA guides require in table 17.5 that there be positive objective radiographic findings of advanced, moderate to advanced degenerative change of either the hip, of the knee, or the ankle. So before we go any further, let's just talk about this. If we had an examinee who had moderate to advanced degenerative change of the hip, knee, or ankle, and that degenerative change of the hip, knee, or ankle left them with some derangement of gait, a antalgic limp with a shortened stance phase, what kind of positive objective physical examination findings would you expect to find in this examinee? Should you do a hip examination? Should you do a knee examination? Should you do an ankle examination? Should your permanent impairment rating due to antalgic limp and shortened stance phase 7% whole person impairment rating? That's a high whole person impairment rating. That's greater than a DRE category 2 at 5% lumbar spine. This is 7%. Should that be backed up by positive objective physical exam findings? It should. In fact, the AMA guides require at least positive objective radiographic findings. So here's a hint. If you provide for permanent impairment due to this, you should have a fabulous hip exam. You should have a fabulous knee exam. Your opinion should be supported by a fabulous ankle exam if the gait disturbance is due to an injury to the ankle. And I can't tell you how many times I review QME reports where the evaluating doctor provides for permanent impairment due to gait derangement without an associated exam. There's no associated physical examination findings of any of the body parts involved with the gait derangement. And see, that's an opinion that simply will not qualify as substantial medical evidence, and that permanent impairment will not be upheld because it's not associated with any positive objective exam findings. Okay? Now the next of the mild impairments, slightly more impairing and providing now for 10% whole person impairment, is an examinee who has a positive Trendelenberg sign, which we typically associate with a injury to the hip or an injury to the peripheral nerves, and moderate to advanced osteoarthritis of the hip, again requiring positive radiographic objective findings. The third category of the mild impairments is the same as category A or B above, meaning we have an antalgic limp with a shortened stance phase, or we have a positive Trendelenberg sign, also degenerative changes on x-rays, but this person is more impaired than either of those two And he qualifies for now 15% whole person impairment. 15% whole person impairment, because the examinee requires the part-time use of a cane or a crutch for distance walking, but not usually at home or in the workplace. Not usually at home or in the workplace. The next level of mild impairment is an examinee who requires the routine use of a short leg brace, in other words, an ankle-foot orthosis. So I want you to think about these examinees here for just a minute. We have an Antalgic limp with a shortened stance phase. We have a positive Trendelenberg sign. We have either of those, shortened stance phase and Antalgic limp, or Trendelenberg sign, plus the examinee requires part-time use of a cane for distance walking, but not usually at home or in the workplace. And then finally, we have an examinee who has all of those and requires a short leg brace, in other words, an ankle-foot orthosis. And let me ask you, which of these descriptions, which of these criteria for permanent impairment require us as evaluators to actually observe the gait, to observe the gait? If you provide for permanent impairment due to an antalgic limp with shortened stance phase, should you do a gait analysis and actually observe the gait? Yes, you should. If you provide for permanent impairment due to a positive Trendelenberg sign, should you observe the gait and observe that indeed the Trendelenberg sign is present? You should, huh? You should. If you provide for permanent impairment due to part-time use of a cane or crutch for distance walking but not at home or in the workplace, should you observe the examinee to walk with a cane? Should the examinee bring a cane to the evaluation with him? Would you provide for permanent impairment due to part-time use of a cane in an examinee who presents to the qualified medical evaluation without a cane? Would you? Would you believe that the examinee requires the part-time use of a cane simply because they tell you that they do? Or would you require some sort of objective finding to substantiate part-time use of a cane? See, the AMA guides are all about positive objective findings, and positive objective findings associated with gait derangement are necessary. They're required. They're absolutely necessary, and thus the necessity of performing a formal gait analysis and a fabulous physical exam of the lower extremity, at least as far as relates to Chapter 17. So these permanent impairments require that we actually observe the gait. How do you do that? Well, we're going to talk about that in our upcoming session, but in today's session I simply want to establish the philosophy of the necessity of ramping up our procedures involved with assessing for gait and gait derangements. Okay? Let's continue with the moderate and severe impairments. Moderate impairment, 20% whole person. 20% whole person. This is a substantial impairment, similar to loss of 50% of the function of one lower extremity, right? 100% loss of function of a lower extremity, such as amputation. That qualifies for 40% whole person impairment. So we're now talking about 20% whole person impairment. This is an examinee who requires routine use of a cane, crutch, or a long leg brace, which is a knee, ankle, foot orthosis. Remember, the last of the mild impairments, the greatest of the mild impairments, was an examinee who requires an ankle foot orthosis. So now we have an examinee who requires a knee, ankle, foot orthosis. It's a person who has loss of function at the knee, the ankle, and the foot, for which they require a long leg brace. Can you see that these impairments follow along a progression of increasing loss of function of the lower extremity? Next is a person who requires routine use of a cane and a short leg brace. So we went from short leg brace to a long leg brace, now to cane plus short leg brace. Next one is a person who requires the routine use of two canes, two canes or two crutches. Now, we're typically not going to see these types of examinees in the industrial setting, but I want you to picture in your mind a person who requires the use of two canes or two crutches. And you've probably seen these types of people. Children with muscular dystrophy, adults with cerebral palsy who have those two crutches attached, those forearm crutches attached, and they waddle along. And this is a significant impairment. AMA guides provide for 40% whole person impairment for the routine use of two canes or two crutches. And then the permanent impairments progress from there. They progress to the examinee who requires two canes or two crutches plus a short leg brace, two canes, two crutches plus a long leg brace, two canes, two crutches, and two leg braces, a leg brace on each lower extremity, and then finally an examinee who's wheelchair dependent. And the AMA guides state here in section 1712, an impairment rating due to a gait derangement should be supported by pathologic findings, such as x-rays. How about also by physical exam? Shouldn't it? Each of these derangements of gait should be associated with positive physical examination findings. Finally, it says, except as otherwise noted, the percentages are for full-time gait derangements of persons who are dependent on assistive devices. So the only exceptions to dependence on assistive devices was the first two of the mild impairments, the antalgic gait with a shortened stance phase and the positive Trendelenberg sign. Those are the only two exceptions. After that, the examinee is dependent at least for the routine use of a cane or the full-time use of a cane or other assistive device. Okay? So let's bring today's discussion to a close simply by reiterating the overriding philosophy of today's discussion. And that is that if you were to provide for permanent impairment due to a lumbar spine injury, let's say you have a lumbar spine case that involves radiculopathy, okay? What kind of physical examination findings would you rely upon to support a permanent impairment rating for radiculopathy? You would have specific physical examination procedures and protocols that you go through, correct? You would be doing range of motion maneuvers of the spine. You would be doing nerve stretch tests of the spinal nerve roots. Let's consider a lumbar spine radiculopathy. You would be doing sciatic nerve stretch tests. You would be doing reflex testing of the lumbar spine nerve roots. You would be doing a sensory exam of the lower extremities and the distribution of the lumbar spine dermatomes. You would be doing myotomal testing. In other words, you'd have a specific protocol that you would go through to assess the lumbar spine. Well, what if you were providing for permanent impairment due to an upper extremity shoulder injury, for example? What kind of physical examination procedures would you rely upon? There are many, and that would include range of motion testing, orthopedic testing, neurologic testing, impingement sign testing, instability testing. You'd have an entire protocol for the assessment of the shoulder, correct? Well, it's interesting because many doctors are providing for permanent impairment due to gait derangement with nothing more substantial than simply statements from the examinee that I sometimes walk with a limp, or I sometimes need to use a cane. When the examinee does not present with a cane and the examiner makes no specific physical examination procedures for the assessment of the gait or assessment of any of the structures associated with disturbance of gait. So doctors, I want to encourage you to ramp up your physical examination procedures, and I want you to ramp up your awareness of the potential impairment due to gait and gait disturbance. As we're going to get into in our next discussion, gait derangements are everywhere. Everywhere you look, you find gait derangement. And I challenge you to go to the post office today, or go to the supermarket tonight, or go to the flea market tomorrow, or go to the movies and find an absence of gait derangements. Almost everywhere you go, you find derangements of gait. We'll talk more about some of the named gait signs and specific pathologies of gait in our next sessions. But I want you to ramp up your awareness of gait and the potential existence of permanent impairment due to gait disturbance. Once that's established, I want to encourage you to ramp up your physical exam and to adopt a formal gait analysis, and we'll discuss all of those topics in our very next session. So this is Dr. Perry Carpenter. I want to thank you for joining me on today's presentation. I look forward to being with you over the next 3 weeks as we get into all topics associated with gait disturbance, and assistive devices. And so for now, I'm looking forward to being with you again next week. And I'm wishing you best of success in your career as a qualified medical evaluator.